Hello, thank you for joining me. My name is Anil Taylor. I'm a consultant gynecologist and I practice in the UK. So in this video, which is the third part of a three-part series on explaining what happens to somebody who is newly diagnosed with a cervical cancer, please search out the other two videos in this series to put everything I say in this video in context. So the two videos that I have previously uploaded, the first one talks about what our initial priorities are as a clinician to quickly find out so that we can then decide what the best form of treatment is going to be. The second part talks about how all the information is gathered essentially from all the scans to decide what the cancer stage is. And this third part is to discuss how all that information is used to decide how the patient is going to be treated. So, in the previous videos, I talked about cervical cancer staging and also talked about how cervical cancer can spread to the lymph glands and why it is important that we find out how much cancer there is so that we can then tailor the treatment accordingly. Now, in terms of how a patient will be treated will be dependent on many factors. So there are various concepts that we can briefly introduce here for any cancer patient. So for instance, whenever we treat somebody for a cancer, there is something called treatment intent. So that can either be curative intent or palliative intent. Essentially, palliative intent means that the cancer is thought to be fairly advanced and that any clinical treatment is unlikely to get rid of the cancer, and that all we can do is either slow things down or to just alleviate the symptoms, but we will never be able to get rid of the cancer completely. Whereas curative intent, which is the most common setting, is where everything that will be thrown at the patient is with the intention of curing the patient so that the cancer never comes back. Now, of course, we would never know whether we've been successful or not, and only time would give us that information. So most cervical cancers are treated with curative intent, unless, of course, they're already fairly advanced when they first are diagnosed. So curative intent can be delivered either with surgery or with chemoradiotherapy. And there is a misconception amongst people that just because somebody is having chemoradiotherapy that it is not as effective as surgery and that we as clinicians have already given up. That is not true. Chemoradiotherapy can be just as effective in many situations as surgery, and there are reasons why we would choose chemoradiotherapy as opposed to surgery, and I will go into those reasons in this video. So, as a rule of thumb, early stage cervical cancers, so meaning stage 1A or 1B1s, are generally treated with surgery. So there is a gray area, meaning there are some clinicians or hospitals where they would consider treating stage 1B2, perhaps 2A, with surgery. And anything beyond that, most clinicians would consider treating that with chemoradiotherapy. And I'll explain why that is the case. So The next thing to mention here is if you are being treated with surgery, that is usually a good sign. What that tells you is that we think that your cancer is potentially at an early stage. And so if you're going to be having surgery, then is it going to be fertility sparing surgery, or is it going to be non-fertility sparing surgery? And so, for instance, if the womb and the cervix are going to be removed, i.e. a hysterectomy, then that is clearly going to destroy your fertility. So if it is going to be fertility sparing surgery, then there are two main options available to us. So one is a cone biopsy, where we would just take a cone of tissue where the cervical cancer has been found. Now, I'm sure you would understand that for this to be successful, then the cancer would have to be really early and really small for this strategy to work. So it isn't a very common option available to us. Of course, if a patient has been diagnosed incidentally to have a cervical cancer because they came with an abnormal smear, they went for colposcopy, they had a biopsy, and the biopsy picked up a very, very small cervical cancer, then in those situations it would be possible to use that strategy. But if when you're examined you already have a visible tumor on the cervix, then it is unlikely that a cone biopsy is going to be enough. Now, if you were very, very keen to have your fertility spared, then there is an operation called a trachelectomy. What that involves doing is removing just the cervix and a little bit of the top of the vagina, but leaving the body of the womb where babies develop. The body of the womb is kept, and the vagina is sewed back to the bottom end of the womb. But what we would need to do is to put a permanent suture at the bottom end of the womb, and any future babies would have to be delivered by cesarean section. And so that is a trachelectomy. And now, not everybody is eligible to have a trachelectomy, so there are various features of a person's cancer that will determine whether a trachelectomy is a safe option. So again, they have to be relatively small cancers where the suspicion of any spread to the lymph glands is not high. So that is fertility sparing surgery. So if you're not too fussed about sparing your fertility, then of course a hysterectomy is the commonest way of treating a cervical cancer. Now, the most common way of doing the hysterectomy for a cervical cancer is a radical hysterectomy as opposed to a simple hysterectomy. So the difference is that with simple hysterectomy, we make the cut very close to the cervix. We hardly take any of the top of the vagina. We don't take any of the ligaments supporting the cervix. Whereas a radical hysterectomy is where we would make the cut such that we are able to take some of the supporting ligaments so that we are able to get better margins, meaning clear margins when we cut out the cancer. We also take a little bit of the top of the vagina as well, again, to give us better margins. So that is surgery. Now, if you have got more advanced cancer, as I said, more than stage 2B, or if there is any suspicion that your lymph glands are involved, for instance, say on the PET-CT scan, the lymph glands are suspicious, then we are unlikely to use any surgical options in that situation. We are likely to choose radical chemoradiotherapy. So what that involves is over a period of about 5 weeks, you're given some chemotherapy to sensitize sensitize your tissues to radiotherapy. But the main way of killing the cancer would be radiotherapy, which is delivered almost on a daily basis over that time period. And as you can see on these images, essentially the womb and the cervix would be roughly in that position, and the colored areas are where the radiotherapy is concentrated in order to kill off the cancer. But of course, the radiotherapy field is over a much wider area, because remember that the lymph glands are in that area shown, and they need to be in the radiotherapy field so that they can also be sterilized. Now, remember that the ovaries are sitting in that position, and the radiotherapy is going to kill off all the eggs, which means that radiotherapy will essentially put you into the menopause. There are certain things that we would do to minimize the impact on the ovaries, but that will be for a separate video. Now, there are some centers where a decision would be taken if you're having surgery, meaning you've got an early cervical cancer, and that you're going to be having surgery. There are some centers that would do what we call either a single stage operation or a dual stage operation. So essentially, a single stage operation is where they would take out do the hysterectomy and take out the lymph glands at the same time. It's one operation. Whereas a dual stage surgery is where we would take out the lymph glands first and have them looked at urgently to find out whether there are any microscopic deposits of cancer in the lymph glands. Because if any are found, then a hysterectomy is not carried out, because that patient will then be treated with radical chemoradiotherapy. So therefore, in a dual stage operation, we would take out the lymph glands, and within 2 or 3 days we would have a result, and within a week or so we would bring the patient in for a second operation where the hysterectomy, the radical hysterectomy, would be carried out. Now, there are some hospitals where this is all done in one sitting, so they would do something called frozen section of the lymph glands. And the pathologist would give the surgeon the information whilst the patient is still asleep as to whether the lymph glands are positive or not. And if they are found to be negative, then the surgeon would proceed and carry out the radical hysterectomy in one sitting. So that is also something that some hospitals do. Now, the reason for considering this kind of stepwise method is because we don't want the patient to get the worst of both worlds, meaning having all the side effects related to radical hysterectomy, because there are some, and these will be discussed in a separate video. And then if the patient then requires radical chemoradiotherapy, then on top of all the side effects for the surgery, they're now going to be having to deal with all the side effects that will go with radical chemoradiotherapy. So had we been able to avoid one set of side effects, then that is best for the patient. So essentially, what we are trying to avoid is what we call dual modality treatment, meaning surgery, radical surgery and radical chemoradiotherapy. We try to avoid that. But in the best of hands, it is still ends up that about 15 to 20% of women with cervical cancer having surgery will end up with dual modality treatment. But this is essentially something that we try to avoid. Now, the next question will be whether, if you are having surgery, whether you can have it as keyhole surgery, because with keyhole surgery, usually the hospital stays much shorter and the recovery is quicker. Now, this is a complex topic, and I will cover this in in a separate video. So up till just a few years ago, we were routinely carrying out keyhole surgery for women with cervical cancer, but recent studies have come out suggesting that there might be a survival advantage for women who have open radical surgery rather than keyhole surgery. Now, there is a lot of debate about this, but I will not cover that in this video. But most hospitals in the UK would be offering open radical surgery. But there are certain situations, certainly at our hospital, where we have a lot of experience with robotic surgery, where in certain circumstances we are prepared to offer robotic surgery. But that is for a separate video. So that is all I want to say in this video. Please remember that this is a third part of a three-part series, and there is a part 1 and part 2, and please search them out to help you understand what happens to patients who are initially diagnosed with cervical cancer. I have uploaded multiple other videos on various topics, on smears, colposcopy, loop biopsies, HPV, and other topics. So please search them out, and if you find these videos helpful, then please consider subscribing and perhaps clicking the like button. Thank you very much, and until next time, see you in the next video.